Well, good afternoon, and I'd like to echo what everyone else has said. It's really my honor to be here today and participate in our discussions about how to increase access to hearing healthcare services to the wide range of populations out there that needs them. My task actually over the next few minutes is to try and synthesize what the hearing healthcare system kind of looks like, if you will. We've already heard about the impact of hearing loss and the many things that it impacts in daily life. And we also know that seeking healthcare or seeking hearing healthcare really is very much delayed in persons who have hearing loss. And one of the questions keeps coming up is sort of why is that? And so I think that by exploring some of the issues around the hearing healthcare system itself, we'll become a little more able to see some of the ways in which we might be able to make some changes in that system that might make some difference. And I think I'll hit on some areas that haven't been addressed so far. Now, I will say that in my assessment of the system, it's really framed both by my clinical experience. I've been very interested, I mentioned I'm a nurse, but I work with older adults. I'm very interested in the interface between policy and practice, and struggling with the issue is how policy influences what I, as a clinician, can provide and offer to the people that I work with to make their lives better. But it's also influenced by my exploration, and one of the reasons I did this was because of my interest as a health and aging policy fellow to look at Medicare payment systems and issues around how one might influence that. So given that, and let me see if I can make sure I know which button to, whoops, that was the wrong one. Yes. The objectives over this next few minutes is first to describe the various stakeholders that are involved in the hearing healthcare system. And these are the individuals that are impacted by any changes in policy that we might make or interventions at multiple levels, or financial coverage, if you will. I want to provide sort of a schematic of a flow, and it's a very simplified schematic, what individuals might experience kind of going through this system. And you've heard some of the experiences of others already today. I want to discuss the key issues raised at these various intersections or phases, if you will, and then summarize and talk a little bit about the gaps in our knowledge and where we need to go from here. Now, I'll have to acknowledge, given the time frame, it's relatively simplified in some ways, but first of all, who are the stakeholders? And there are a lot of them. The first three, consumers, healthcare providers, and hearing healthcare providers themselves, are ones that I'm going to focus on in terms of some central parts of the hearing healthcare system. But it's really important to think of this as a contextual issue within society itself. So we have the consumers, the persons with hearing loss, their significant others. We have the associations that represent them broadly and try to advocate for their needs. And then we have the healthcare providers, and we haven't addressed those individuals. I come out of that framework, but we really need to think about them as well. And the hearing healthcare providers also that are the people who actually offer the services, like you just talked about the kinds of services that they should be offering. But then the other groups really are very important in terms of contextualizing this and impacting what is offered and what goes on within that direct care model, if you will. And they include the Centers for Medicare and Medicaid Services, because they're, Medicare is under the auspices of them as for sure. Other healthcare companies that actually follow the dictates or at least sort of model some of their programs around the things that Medicare offers. And then policymakers and legislators, because they're very interested in and concerned about the cost of health care. And finally, I do want to sort of emphasize public health professionals. That was raised a little bit, but we tend to overlook them. And we actually do, when you look at it, have national public health policy related to hearing health care. 2020, Healthy People 2020, they review these goals every 10 years, and there's always been one on hearing. And so you can see that one of their goals is to increase the proportion of persons with hearing impairment who have ever used a hearing aid or assistive device. They're focusing on increasing the proportion who have hearing examinations and increasing the use of hearing protection devices. And then if you go on their website, you'll actually see that they have subcategories of how, of sort of what their goals are to achieve that. Unfortunately, these goals get made every 10 years, but most people don't even know they're there. And certainly healthcare providers don't know they're there. Someone once mentioned to me when we were talking about this, because I listened to a lot of webinars around this, when they use them is when they're writing grants. And they go and use them as a substantiation for why they should be funded. That's probably a good reason as a researcher, but probably not the best one. The other thing that needs to frame this is the payment system, because that is sort of critical to how people think about going into and moving through the hearing healthcare model. And as all of you really probably already know, Medicare is the primary payer for at least older adults. And Medicare has three areas that it needs to consider when it thinks about covering a service. One is it has to fall within the defined Medicare benefit category. So it has to be something in Medicare. It has to be reasonable and necessary for diagnosis and treatment. These are sort of the goes. They say that if it falls within these parameters, they can pay for it. However, it can't be statutorily excluded from coverage. Well, unfortunately, when you look at the original Medicare bill itself, the legislation that set up Medicare, Medicare has a statutory exclusionary clause related to hearing health care. It says no payment may be made under Part A or Part B for any expenses incurred for items or services, and it covers vision, dental, and hearing. And people always ask why, but going back to 1965, there were different reasons for different perceptions of what Medicare should be covering. And while it's changed for other areas, it has not changed for this, this particular area. So I always tell students that we'll give you a new heart, but we won't be able to give you glasses, dentures, or hearing aids. So it's unfortunate at this point that Medicare has an exclusionary clause. But when we think about the hearing healthcare system, in a sense, we can think of it simplistically in sort of three areas. One, there's this consumer who really has to go through the primary care setting in order to sort of get to the next system, which is the hearing healthcare. They can go directly, but as I mentioned with Medicare, one of the issues is the thing that you need to have coverage is for appropriate diagnosis and treatment. So most of the time you want to be referred because that implies that you're being diagnosed for a condition or something that's important. So there's sort of this barrier, and we'll probably get into that a little bit more. So one of the things, if we look at the consumer, we've really already addressed a lot of the issues related to consumer. They attribute it to aging, and they think that it's normal. It comes on slowly and subtly, and so they're really not aware. They don't prioritize, and they're very concerned about the cost. They also often don't think that the hearing aids work. They have very old perceptions of what's going on. I hope that some of that's changing, but it's very true. And I do think that the stigma related to aging comes out a lot in my own research. I have to acknowledge that I think sometimes the hearing industry itself doesn't help that too much, because every time we look at the media in terms of what it advertises to persons who think about getting hearing loss, you always see the same sort of thing, almost invisible. So small, no one will know. And what that does, I think, is just set up the perception is you really don't want anyone to know that you have hearing loss. Whereas I think in some ways, if you want to communicate, it should almost be a badge of honor to say, I really want to hear what you're saying. So I think that's a negative perception that maybe we could make some changes pretty easily about. But I think that in one sense, the perceptions of older persons themselves or people in general who have hearing loss wouldn't necessarily be the barrier that it was if it was attended to at a primary care setting. And that's where we have to turn to the healthcare providers. And although the numbers aren't terribly well documented, most of the recent data, there was the review for the Preventive Health Services Task Force recently that looked at, that service actually is an independent organization that reviews screening processes like mammograms, chest x-rays, and they do a very thorough review of the literature, and they come up with recommendations about, based on the evidence, very much based on the evidence, is it appropriate to screen? When is it appropriate to screen? Who should be screened? So they did a review, and two pieces that I'm going to mention come out of it. One is most don't screen, but what they found is that between 40 and 86% admitted not screening routinely, even though they said that they felt hearing loss was an important issue for older adults. And they said reasons were lack of time, perceptions that there are more pressing issues, lack of reimbursement at their level. So they think about doing an exam, they think more, I think, about audiograms and some thorough things like that. So it's not routinely screened. And actually, in my own work, we interviewed 91 dyads, and of the 82 that had good recall, 85% said that their practitioners never asked them or screened unless it was actively asked, like said, I have a problem, I want to be referred, in which case the person might refer them. We had one woman who kept talking about the fact that every year she went to see her practitioner who knew she had hearing loss, looked in her ears, says they're very nice and clean. And another who mentioned that his wife finally got him, and his wife collaborated this, to ask the practitioner about it and said, my wife thinks I have a hearing loss, and the practitioner basically said, wives say that. Needless to say, the wife was not very happy. So it's not screened. It's a major problem from that standpoint. But unfortunately, it was reinforced, and this was brought up by Barbara, by the fact that what the Preventative Services Task Force also said was that they concluded from the review is that the evidence isn't sufficient to assess the benefits or harms of screening for asymptomatic adults age 50 and older. So unless you go in and complain, they were not saying there was any data. Now, technically, if you read this, it's a neutral statement. There's no good data one way or the other. But from the standpoint of the primary care practitioner who's busy, it became I shouldn't screen. It's not needed for me to screen. And one physician association actually came out directly after that and said they would no longer recommend it. So that they said that additional research is needed to understand the effects of screening compared with no screening on health outcomes to confirm benefits of treatments and so forth, which is one of the areas that we definitely need to look at. So if, however, the person is referred, they actually enter a very confusing system in many ways themselves, far from a unified whole. We have audiologists, and audiologists often have PhDs, or now they may have a doctor of audiology because that's the entry into practice requirement. But there are also other practitioners. There's speech-language pathologists, there's otolaryngologists, head, neck, and ENT physicians. These are physicians with special training in head and neck and audiology and so forth. And they're the hearing instrument specialists. And these are individuals who are trained more to just dispense hearing aids, if you will, although they get a broader training than that. But they are state regulated and state defined in many ways. So there's a lot of overlap in terms of the type of individuals the person seeking treatment might end up seeing or not seeing, and they might often offer very different services to the persons who come to see them. And because these professionals, they don't agree with each other in many cases about the types of things that would be helpful to have their practices continue to function. Most of the audiologists are not in favor of Medicare. Actually, most of the groups are not in favor of Medicare because they're quite concerned that the payment reimbursements won't keep them in practice. Most of the audiologists would like direct access so people could come directly to them, but not the otolaryngologists don't think that's a good idea. So they don't agree with each other in many of the ways in which policy should change. And needless to say, they each have their own association that then argues for their particular viewpoint at various levels in terms of Congress and so forth. So they speak, again, there's a lot of tension then across this, and the tension, of course, now is getting larger in many ways because of the new models that are coming out and the various challenges that they're facing in terms of their own practices. So these, as I say, the tension is going. The other thing that is related to this, too, is the way in which the services are charged within the system itself. And in general, most audiologists, and this is changing, there are a lot of audiologists now that are arguing for unbundling of costs. But basically, the cost of the hearing aid is not really what the person's necessarily paying for that they see up front, but it's bundled into most of the services that the person might be offering. And I don't think the consumer always really appreciates that. so that they need to figure that that builds into the return and all those kinds of things as well. And that needs to, if you unbundle, it makes it a lot more transparent, if you will, because they see what the cost of the hearing aid is, they see what the cost of the services are. So that's an area that I think people are looking at in terms of potentially changing. I will note that Medicaid, which is for low-income individuals and high healthcare costs, older adults or adults who are dual eligible, it's very state-specific. In most states, it will cover things for children, but there are a lot of states that don't do anything for older adults, and if they do, what they cover varies greatly. But it's good to see, and also it can change because of somebody else mentioned that earlier. I think that the unfortunate part about Medicare, Medicaid is that given the state's financial condition, it may change at a fairly, back and forth kind of way. So in summary, I think what I'd like to emphasize is that the hearing healthcare system is really not coordinated in terms of offering its services at most of the level. And right now, I sort of talk about in terms of almost a menu of offerings with access restricted by the lack of coverage by Medicare and other insurance companies. Now, I'm ignoring the VA because the VA does actually cover hearing services. Consumer beliefs about hearing loss and also the services, because sometimes they do feel like they're just being sold hearing aids. The cost of hearing aids as currently sold, at least as bundled and as the way they're available. I think a big area is the primary care practitioners, also lack of screening and referral. There's really very little education around hearing loss in the primary care or in the healthcare fields. They get a smattering related to that, and it's not, even geriatricians often don't get as much training, you're nodding your head, in hearing loss as those of us who are interested in the area really think they need, because when I go talk to people, I really find out they don't know. The range of practitioners with varying views and so forth all interrupt and make things a lot harder. So what we need in terms of gaps in related research needs, as I'm summarizing here, and there certainly are more, is one, we need to generate data on the benefits of primary care screening and the effectiveness of hearing aids. That's been something that's been echoed, I think, across today. We need to evaluate models of care that may be targeted to individuals with varying levels of hearing loss. And I do think we need programs to inform older adults about hearing loss, the availability of options, and how to be educated in consumers when seeking treatment. Educate healthcare practitioners about hearing loss and available resources, and continue to emphasize the hearing loss as a public health issue. And I want to sort of step back and also say one of the things about screening, and it was brought up a little bit earlier, that's always a concern, and it's got to do with informing older adults about available options, is that when I talk to low-income clinics about screening, what I get from practitioners is, why should I screen? I can't offer them services. They can't pay for the hearing devices. So it's a big limit for low-income centers that don't have access to the services, know their clients, and they're afraid they're going to raise expectations by screening. So I think making more the screening easy in those settings, inexpensive, and considering the fact that the person who doesn't have the resources for some of the things we'd like to give them at least understand many of the communication issues and other kinds of devices that will help them stay engaged. And so long term, I'm hoping that we'll move toward common ground and come to some understanding. And I'll end there. I think I'm staying in time, I hope.